Assalamu alaikum, Sadiq. Can you hear me? Brilliant, great. Where's the time we have? By the way, what time is that event on Thursday? Not on Thursday. In no, not today. The one for Manchester, because Dr. Camille needs to know the dates that he potentially needs to book off. Okay, fine. So I've texted on the group anyway, so we can ask. I can ask him, and you can see the slides, right? Okay. And you can see the slides? Brilliant. Okay, perfect. That's fine. Absolutely fine. Okay, start. Evening, everyone, and thank you for the penultimate CP Community Pharmacist Consultation Consultation Service webinar that we're doing today. And I want to address something very, very important today, which is probably more important than any of the webinars that I've delivered. And it's all about having the right mindset. Now, a lot of you have got in touch either directly through Sadikor or through LinkedIn, and there seems to be the same question asked again and again. And I'm also, having spoken to hundreds of pharmacists now in the space of nearly a year, a lot of pharmacists are, who I've spoken to, I shouldn't use the word a lot, but there are pharmacists who I have spoken to are not really happy with what they're doing at the moment. Whether they're working in a GP practice, whether they're working in community pharmacy, or whatever it is that you're doing. And they're getting really stressed out about it. So I've had pharmacists speak with me directly about not being happy with working in a GP practice, not being valued. I've had pharmacists get in touch and say that community pharmacy is boring, it's not for me, I'm not enjoying what I'm doing. And there seems to be a bit of confusion on how to tackle this problem. I can only, if it is a problem, I can only talk to you about what I've done and shed some light on it. What I realized about a year ago is the key to anything you want to achieve is having knowledge. Knowledge in any shape or form. And then it's about applying that knowledge and obviously being able to market it and so forth. Now, I've always had a passion for medicine from the outset. I've always absolutely loved medicine. I get a thrill out of that knowledge. If it was up to me, I could sit and read anatomy, physiology, pathology textbook all day, all night long. If you were ever going to buy me a gift, I would want a book. That's what I enjoy. And what I realized is, personally for me, is I don't need any extra titles behind my name. I don't need to go out there and change my name into doctor. I was happy in my skin, and I was happy with the idea that if I was to apply myself to this field and really focus on what I'm doing because I have a passion for it, certainly I would also not help people, the profession, but also benefit financially. I also had this question that would people pay, would people not pay, would people pay, would people not pay? About a year ago, I went to a talk by Tony Robbins. I attended one of his talks, and I attended a talk by, what's his name? God, he's always on LinkedIn. Not Gary Vee, it's somebody else. Not Gary Vee, it's not Grant Cardone, it's somebody else. I can't remember, but he's always on LinkedIn. And my brother took me to one of his events, and it was one of his master classes. Dr. Camille knows about it quite well as well. And on that day, he had signed up 7 students on his program, and they had paid £20,000 on the day. That's when I realized that you need to stop judging people, and what you might value as not worth it, somebody else will value as worth it, and people are willing to pay. Why that was important for me was because I realized that I need to stop assuming things and saying, oh, would people pay for the service? Would people pay for the Medline training? Would people pay for this course, that course? Or who's going to pay £7,000 for a course, or £10,000 for a course? Or who's going to pay £30 for a consultation? That broke all my fears. That took away all my false beliefs that I had. And it changed everything that I did from there onwards. I asked him, why £20,000? And we went through the whole concept of valuing your time, giving value to people. We also spoke about me charging for consultations and so forth. So don't be scared. Don't be scared of valuing your time, and don't be scared of stepping out your comfort zone and doing what you enjoy. If you're really not happy with what you're doing, you need to stop doing it and do something else. If you're going to keep doing the same thing and expect a different result, it's not going to happen. You need to focus, find what you enjoy, stick to it, you'll get results. It's taken me 1 year, no, it's taken me 2 years of working hard on myself, on something I enjoy, to be sat in this situation where I've got, at this very moment in time, 12 people whose precious time that I'm sharing, and all the other webinars that we've done and so forth. So my advice to everyone is who's not happy about what they're doing, or wants to do something, or isn't really able to do it, is to trust yourself, find what you enjoy, and apply yourself to it. Once you've got that, you can make a huge difference. You will definitely benefit financially. Don't worry about what people say. Is it going to work? Is it not going to work? If you apply yourself, it's going to work. And if you've got knowledge, which I've always said is wealth, you will always do well no matter what happens. One of my biggest inspiration was Noman Ali Khan, who's an expert in Arabic in the Quran, and he is an expert in linguistics. He doesn't have any qualification in linguistics. He's not done any sort of degree in linguistics. He's just applied himself and is an absolute genius. One of my other good friends, Julian Baker, has no qualification in anatomy, but he's one of the gentlemen who I'm sharing my class with for the anatomy, and he's teaching all over the world. What he was a sports therapist before that, or a manual therapist, that's what it was. No qualification, but he's got more knowledge than a surgeon in its anatomy. He's got more knowledge than an anatomist in its anatomy. You'll be surprised at the knowledge that he has. You just have to keep your mouth shut when you're with him. Doesn't matter what title you have behind him. And he's making money. And all these people who attend the anatomy courses are not pharmacists, doctors, and nurses. They're all manual therapists, and he's charging around an X amount, and his classes are full. Who would want to go to a class of anatomy if you're not a regulated healthcare professional and just open up the human body? He gets people from all over the world, from Australia, New Zealand, Poland. That's what made me realize if you give value to people in any shape or form, things can't go wrong. So there is a right way to do it. You apply yourself, you work hard. If you're not happy with what you're doing, upskill yourself, get knowledge. You don't have to come to Medline. You don't have to come to any other training program. Just remember these words: apply yourself, focus on your knowledge. If you're not happy with what you're doing, get in touch. You can make a difference. You don't have to do the same route every single day, because how I see it is a lot of these big institutions, and I'm happy to say this, they have no vested interest in you being financially free. Absolutely not. They want us to stay stuck in that rat race where we're only focusing on our daily lives, and they can do whatever they want in the world, whether it's climate change, whether it's, politics. You know where I'm headed with this, because we're so busy on the daily running that we don't get a chance to think, and that's what they want. So my advice to you is work for yourself. Well, I wouldn't say work for yourself, but be entrepreneurish if that's what you like. Enjoy what you do and do what makes you happy. I enjoy what I do. I'm happy at 7:30. We can talk for 4 hours. I'm more than happy to do it. So that's my only advice. And to all pharmacists, that now's the time to upskill yourself, gain knowledge in any field, whether it's computer sciences, whether it's medicine, gain knowledge in it, and people will pay for that knowledge. So I just wanted to set that straight. There's plenty of negativity out there. There's plenty of people who are not going to encourage you. I don't want to be part of that. And I want to encourage you to do what you enjoy. Any help you need, get in touch. But you can do whatever you want to do if you choose to do it. I was so close to bankruptcy. So close to bankruptcy. We had banks involved. We had letters. My family went through so much stress. It got me into a divorce as well. Been there, done that, worn the t-shirt. And what I realized after that is if you focus on what you're doing, apply your knowledge, there's nothing that can stop you from doing well. So that's extremely important. Now, moving on to the thorax, which is what we're discussing today. Very, very important topic, a very interesting topic. We're going to break it down into 2 halves. Half an hour, I'm going to teach you anatomy. Half an hour, you have to take a history. You all need to chip in. We're all going to work on this together because we don't want this to be a lecture. It's something that you're all familiar with. We've all got to start to get into the habit of taking a history and seeing how we deal with the case of a cough. Let's share ideas and see how we do with this. So the thorax is basically the medical term for the chest. It's shaped as a cylinder, okay? And what we have is four major parts that constitute to this structure here, okay? We have the vertebral column at the back, so posteriorly, which means the back. Anteriorly, you have the sternum. Who knows what the normal word for sternum is? Anybody know what they call the sternum? Like, if you were to mention it to a patient, what would you call the sternum? Just put it on the chat if you know what it is. If you're not sure, I'll mention it. But you've got the sternum, we've got the costal cartilage, and we've got ribs here. Okay, so the thorax is basically a cage. Absolutely, yes, breastbone, spot on. And if you go back and look at the actual Greek origin for the word sternum, you'll see something interesting how it all kind of comes about. But the thorax is basically a cage. It's a very important cage because it houses some very, very important structures. So we know what we have in the thorax. So what you need to know, that we've got this cage. Inside the cage, what do we have? We've got our lungs, we've got a heart, we have I want to get this right, on the right, we've got the liver, we've got a bit of stomach, we've got our kidneys, and obviously very, very important blood vessels, very, very important blood vessels. And whatever you believe in, but with the will of God, it's been designed in such a way that these structures are protected. These structures are protected because they're delicate structures. So what you need to remember is the thorax is known as the cage. It is there to protect the structures inside, also plays a role in inspiration and expiration. So it has a role in ventilation and so forth. And how it's formed is at the front, you have this breastbone known as the sternum. You have cartilage, you have bone, and then behind you have the vertebral column. So it's four parts. If you're unsure in the difference between a bone and cartilage, you want to check that up, but they're both basically connective tissue. And there is a difference in terms of their function and in terms of the strength that they have. So there's different types of bones. that you can have long bones, compact bones, spongy bones, and so forth. And costal cartilage is a type of connective tissue. And it's very important because it can actually, it's not as strong as a bone is. As we know, you have cartilages in the parts of the ears and so forth, and parts of the nose as well. So, you know, it can break and so forth. But the main thing from this slide is just to remember that we've got this cage, and in this cage we have some important structures. Those structures are important for you because if you have any pain around this area, you need to understand that that pain could be any one of these structures. So moving forward, looking at the chest itself, we have the actual ribs can be divided into different parts. So we have true ribs, false ribs, and floating ribs. So does anybody know what the difference in true and false ribs is? So what's the difference in true versus false ribs? Any ideas? If you're not sure, I'll quickly run through it. So basically true ribs, as you can see, they actually articulate. So if you're not sure what the word articulate means, it means when two bones join, it's that joint. So you can see that these ribs, 1, 2, 3, 4, 5. I can't see your text. Oh, okay. Here we go. Now you can. Should be able to see it now. I think you can see it now. There you go. That's what I wrote. So if you have a look at these bones, 1, 2, 3, 4, 5, 6, 7, can you see how they're directly connected to the sternum? That's why they're called true ribs, because these will connect directly to the sternum. False ribs, which are ribs 8, 9, and 10, they will connect to the costal cartilage of rib number 7 and then articulate with the sternum. That's the difference. That's why they're known as true ribs and false ribs. Clinically speaking, it's not that relevant, to be honest, but it's worth you understanding that you have the first 7 ribs connect directly to the sternum. The remaining 8, 9, 10, they have to connect the costal cartilage of the rib at the 7th rib, and then that connects to the sternum. Is that clear? Clear? Everyone got that? Yeah, nothing tricky there. These are known as floating ribs because you can see that they don't really connect to anyone or anything, sorry. They literally float. So we've got 11 and 12 just float. So ribs can be broken as true ribs, true, false, and floating. Clinically, is that relevant? Probably not. Can be, but not for what we're doing. So it is clinically relevant if you were a surgeon and so forth, but not for you as a pharmacist. And the space in between here is known as intercostal space. So when you're percussing, which we'll be discussing and auscultating and so forth, this is the space that you're looking for. And this is what we use to count ribs as well. That's known as the intercostal space. So in between the ribs, you have this intercostal space here. And you can actually feel it on yourself. If you feel your chest, you can feel the bone. And then in between, you can feel a space, then you can feel a bone, then you can feel a space. That's known as the intercostal space. That is relevant, and we'll go through that in a second. That's going to be relevant. Are we clear on that? Everybody happy? I think so, good. So true, false, floating ribs. So now you know that true ribs connect directly to sternum, false ribs don't directly connect to the sternum, floating don't connect anywhere there. Vertebral column. So this is the vertebral column here. Have you ever seen this sort of slide before where you have a discharge letter or the patient goes, I've got a slip disc at T12, or my L5 is broken, or my C7 hurts? Is everybody aware what that means? Are you all clear with how the vertebral column is divided? So we have the first 7 vertebrae are known as cervical. The rest 12 are known as thoracic. You then have the lumbar, sacrum, and coccyx. These actually, some people, they say it's 4 bones, but it's actually probably just one big fat piece, but it can be divided into 4 bones. But this is relevant because you could technically have, when we're talking about the vertebral column, and when you're trying to identify structures, you will use these words. You might be talking about something like a slip disc, and it could be at T4, and that's the 4th thoracic vertebrae. It could be, it could be L6. It could be the lumbar vertebrae. It could be my, C7 or L20, whatever it is. So that's quite important for you to understand that the vertebral column is divided. The first 7 vertebrae are cervical. The rest 12 are thoracic, lumbar, sacrum, coccyx. This is quite important if you're going to be dealing with back pain and so forth, so you can identify structures. So it's going to be important for you to actually memorize this particular anatomical language, so you're able to use that in practice. So next time you have somebody with back pain, and it's quite easy to count ribs, to count the vertebra, you can run your fingers down, you can actually count it, but that is something that one would do on a practical basis. So the next thing that we're going to move on to, is that clear for everyone? Sadikur, you're saying yes to everything today. I think you're really on the ball. Absolutely. I think you've all got this. For respiratory, it is important because where the lungs are going to lie, that is quite important for where the lungs lie. So you need to know this is T12, this is L5, this is, and so forth. So just remember that slide. But I think most people might be comfortable with that. If you're not, then just let me know. But that's basically the summary slide, because I really want to spend time focusing on history taking today. So there's nothing too difficult there. If you're unsure, we can, when we do the Q&A, you can ask me questions. But clinically speaking, just remember the different regions and how the vertebra is divided into different regions. The sternum, the breastbone, has different anatomical landmarks. The most important for you is the sternal angle, this here. So the sternum has 3 different parts. It has the manubrium, you have the body, and then you have the xiphoid process. So it's divided into 3 separate sections. Does anybody know why the sternal angle is important? So this joint here, which is between the manubrium and the body, also known as the manubrium sternal junction, or the joint, why is this important? Why is this angle so important, this sternal angle? Any ideas? Does anybody know why the angle is? Yep, that's right. It's not the second intercostal space, but Nazmus, you're right. We're going to get there. It's actually, in a second, we can use this angle, and you can literally, yes, second rib. You can actually run your fingers down. So literally get your finger, you can feel right here and run it down, and you can actually feel like a bump, a very subtle bump. Right opposite that is the second costal cartilage. And this is what you're going to use to be able to count rib spaces and count bones, because we're going to use this structure to identify what's underneath. The reason we want to identify what's underneath is so we can go ahead and make a diagnosis and so forth. We don't have the luxury of opening up and doing surgery, so you have to use what we call landmarks to be able to identify internal structures by using external surfaces. We'll get to that in a second. What's important for you here to remember is the sternal angle. Yeah, the sternal notch is here. It's also known as a jugular notch, sternal notch. The sternal notch is just literally that opening here. That's the sternal notch. A notch is like an opening, so it's different to the sternal angle. Yeah, the sternal angle is different. The sternal notch is different. A notch is like an opening. So if you run your fingers down here and you literally press just before you get to the ribs, or just before you get to this opening over the clavicle is, where your collarbone is, you'll feel like an opening. And in here, that's the sternal notch. that's different. It is important because you've got the brachial plexus and so forth, but we're not going to go into cervical ribs and so forth because it's not worth it right now. But you need to remember the sternal angle because you need to start practicing on this to be able to auscultate and so forth. If you can't feel it on yourself, you're not going to be able to feel it on a patient. You must identify this structure. That's why there's certain things that you can teach on a webinar. There's certain things that are difficult to teach on a webinar, require hands-on practice for me to actually show, look, that's the sternal angle and so forth. But you could use your fingers, literally slide right the way down, and you'll be able to feel a notch, not a notch, sorry, a ridge. I can feel mine here. So we now have this broken down. You've got your thoracic cage, you've got this breastbone, you've got the lumbar, the vertebrae at the back. And here you can see that the costal, this angle is directly adjacent to this costal cartilage. That is why you can now count the rib spaces. Why don't we use the first rib as a landmark? Why is the first space not a first rib not a landmark to count ribs? Yep, it's the clavicle, which is the collarbone. So you can feel it on yourself. Literally get your hand, have a feel, try to find your first rib. You're not going to be able to, because just here, literally just here like that, here, and on this side here, the collarbone connects. So it's very difficult to feel that rib. Very difficult to feel the first rib. So the best we can do is go to the second rib and then use that to count the various rib spaces. That's why you can't use the first rib as a landmark to be able to count. And what's important about the anatomy here for you to remember as a pharmacist, obviously a lot of it's important, because if you were doing surgery, you would be being taught totally different. Because if you were going to stick a needle and do, you know, an incision here, you would need to know the anatomy of where the nerves are and the blood vessels and so forth. But we're not discussing that because you're not doing that. But for you, what's important is to remember that we have this cage. It has these important structures. In order for me to understand or be able to articulate what's at the top with what's at the bottom, I need to be able to count rib spaces and then know what the structures are. So I'll go through that in practically. No, you don't have to lie down. No, it's easy. Obviously, if someone has a lot of subcutaneous tissue, it's a bit harder, but you can easily count ribs. Like, here's my third one, fourth one. It's not difficult. It comes to practice. The more you do it again and again, you count ribs. You don't need to lie down. Yes, it might make it easier, but if you have a patient in front of you who auscultate, you don't put everybody on, get them to lie down. But it's you don't have to be lying down. No, you can feel it yourself, and that's something that you're taught on a practical session. It's difficult to teach on a webinar, but if you, honestly speaking, how I learned it was literally just feeling it on myself. I one day just sat there and thought, you know what? How am I going to count ribs? I don't get it. I can't just put the stethoscope anywhere. Watched a couple of videos, started to have it. Thought, oh yeah, I can feel my rib. That's true. In between here, I have a space. In between here, I have a space, and then you can count the ribs. But identifying that angle is important. And this is why, as much as you can learn things on your own, you still need someone to teach you to make sure you're doing it right. So yes, self-teaching is great. I'm an advocate of that, but you still need someone to show you in case you're doing it wrong. So you're gonna, how do we apply this knowledge, right? That's the question. You've taught us about, we've got ribs, we've got bones, we've got all these important structures. So what? Yeah, we know that anyway. Well, this is what's important, is that sternal angle will allow you to count rib spaces. If you can count rib spaces, you then know where to put your stethoscope, because you can use the rib spaces to identify certain elements of the heart. You can also use the rib spaces to identify where to auscultate. Because what's wrong when putting a stethoscope on rib number 12? What happens if I put a stethoscope right here or right here? Rib number 12 or rib number 11? What happens if I get my stethoscope and started to listen here, right here, where I can just see the margin? What's wrong with putting a stethoscope right there? What's wrong with that? Any ideas, anyone? Why can't we just put the stethoscope, just feel? Yeah, it's not, there's no valve, it's listening. Yeah, absolutely. You're listening to the liver. The lungs itself don't expand all the way through to the ribs. You have liver sat here, you have the diaphragm here, you've got the kidneys here, you've got, or the kidneys are more posterior, you've got the part of the stomach here. So if you put a stethoscope here, you're not listening to the lungs, you're listening to the liver probably, and you're not going to hear anything. The lungs don't extend all the way down. 1, 2, 3, 4, 5, 6, 7, and when you inspire, up to 8. But literally, this is as far as it's going to go. So if you start to put your stethoscope in the wrong places and you can't count rib spaces, you are not listening to the lungs. You're probably listening to a different part of the anatomy, and then you're going to, I don't know, you might, something can go wrong. Other than listening to the stethoscope, what else is a mistake with you starting to pretend that you're doing a respiratory exam, but you're gone way too low? What happens if you start to percuss? So when you start to do this, what kind of sound would you, yeah, you're going to hear a dull sound. Why is it dull? Does everybody know what dull means? Yeah. So does does everybody know what, when you're listening to different sounds, what a dull sound is? If you're unsure, I can run through it. Best example that I gave is if you go to a wall that is absolutely full of concrete and you were to literally tap on it, it'll give a different sound versus a wall that is hollow. So if you hear this wall, that's a hollow wall. That's a hollow wall. Behind here, there's definitely something behind here because that sounds not normal. But if you do the same sound on a solid piece of wall, it's going to be a very different sound. Do it actually, how the best way that I do it on your bone. Tap your bone here and tap your chest. It's totally different. That bone is absolutely solid, and that's why if you start to, if that sound is on the chest, then it can suggest that there is a pathology there. But if you're knocking, or what we call percussing, and it's below the level of the chest or the lungs, sorry, rather than the lungs, it's not there's something wrong there. What you're probably percussing is the liver. So it's really important for you to be able to relate this structure to what's underneath. Is that clear for everyone? I just want to make sure that if you find out that you're auscultating at rib number, below rib number 8, you've got at rib 9, 10, 11, you're most likely in the wrong place. You're auscultating something else. The best thing to do is auscultate all over, listen to sounds. Put it rib number 12, put it rib number 11, put it rib number 1, put it rib number 3. Listen to the different sounds. It will make sense to you that, wait a second, this is a different sound. What's going on here? I'm actually listening to the ribs. Or am I listening to, am I listening to the liver? Am I listening to the actual lungs itself? So that's I want to make that clear. What you need to remember from this side, importantly, is the left lung has this cardiac notch, so it's smaller because the heart sits here. Okay. Other thing that you need to know is the lung is divided into 3 lobes. You have the superior, middle, and inferior lobe. And the right lung has 3 lobes, and the left lung has 2 lobes. For you, in terms of a pharmacist who wasn't having access to X-ray, who wasn't actually defining any sort of pneumonia, you won't be using that knowledge much. But it's important for you to understand this. Why? Because if you read a discharge letter, it goes that the middle lobe was, the parenchyma of the middle lobe was, had a pneumonia. It won't throw you off that what's the middle lobe. Not everything that you learn about anatomy or physiology, pathology is going to be relevant to what you do, but you have to have a base understanding of it. Otherwise, you can't build on that knowledge. And if you can't build on that knowledge, you can't self-teach. You're going to have holes in your gap in your knowledge. That's why it's important for you to have strong foundations. Not everything is going to be relevant. You know, when you go to school and they teach you stuff, not everything's relevant. You could say, why don't you get me from A to Z straight away? But you need to have a good understanding of the fundamentals to get from A to Z. It's not, you know, you can't run before you can walk. So what you need to remember here, that the right lung has 3 lobes, the left lung has 2 lobes. You have the heart that sits, known as the cardiac notch. You also need to remember that the right lobe can trap foreign bodies. Why? Because it's the actual trachea that bifurcates or divides into 2. So bifurcation, it's called bifurcation, means it divides in 2. For some reason, it's bigger, it's wider. So if you have like a trapped object, it's normally in the right lobe or the right lung because of the anatomy. It's a lot more straighter, a lot more bigger. So if you swallow something, it's most likely to be stuck in the right chest. And that's the reason for it, because of the anatomy, that the fact that bronchi, that you know, the bifurcation here is it's a lot bigger and a lot wider. When I'm not going to go too much in the pleura, but what this basically is your lungs have a outer covering, and that outer covering is known as pleura. And if you're really confused about this, I can send you a wonderful explanation, which is a picture which really makes a lot of sense. But this is just an outer covering that you have to be aware of. The part that directly covers the lungs is known as the visceral pleura, and the part that actually covers or connects to the actual wall or the ribs and so forth is known as the parietal pleura. In between here, we have the pleural cavity. So if you're unsure about this, we can discuss it in the Q&A. What's relevant for you, you might come across, I think it's known as pleuritis, and that's just this inflammation of this covering of the chest. The reason you have a covering is so it's able to glide, because look at all the other structures here. Imagine if there was no covering. They're going to rub across each other, it's going to be painful. If you didn't have this cavity, this space here, the lungs can't extend either. That's why God has made this beautiful structure that has this inner covering and outer covering. It's known as pleura. It's literally just a covering. The relevance of it for you is relevant, but I don't want to bob you down too much in it and kind of like confuse things. But if you don't get it, we can go through it. So what you need to remember from this is the thorax houses major organs. You have the lungs, you have the heart, you have the liver, you have the kidneys, you have the stomach, you have important vasculature like the aorta. Who's heard of a dissecting aorta? Who's heard of a dissecting aorta? Anybody heard of a dissecting aorta? It's basically where you end up getting basically like a perforation or damage to the aorta. It causes extreme pain in the center of the chest and right at the back, like absolutely, you know, very, very bad pain. Again, if you don't understand the structures here and you don't know what lies underneath, how are you going to be able to think that possibly this person could be having a medical emergency? He's having a break in the aorta. That's the severe pain that he's having. So you need to understand this. You also need to understand that the lung itself does not extend all the way to right at the bottom of the ribs. It does stop, so you can't be putting your stethoscope everywhere. And from the side, it extends all the way across, which we'll go through that in a second. So when I spoke about X marks the spot, this is what you're thinking about when you're using your stethoscope. This is where you're thinking that, okay, this is what I can put my stethoscope. The lungs or the pleura will extend about, I think, 2.5 centimeters above the clavicle. So you would always be auscultating above the clavicle. So you might have seen physicians or clinicians put the stethoscope just above the clavicle. This is why, is because the lungs extend above the clavicle. Can you see? Right there. It does not go all the way to rib number 10. It doesn't extend that far. So if you're going to be having a stethoscope on rib number 10, you're definitely listening to the lungs. You're listening to probably another structure that's underneath. But rib all the way up to rib number 8, you're safe. 5, 6, 7, 8, you're safe, because when you inspire, this is going to go all the way down. So rib number 7, 8, you're safe for using the stethoscope. And also, interestingly enough, you can use the sternal angle to listen to various parts of the chest, of the heart. So we have the aortic valve, we have the pulmonary valve, we have the tricuspid valve, the apex beat. So if I really wanted to listen to parts, and I'm listening to murmurs, I'm listening to abnormal heart sounds, I'll have my stethoscope. I will feel for that notch, or what we call the sternal angle. I'll then move laterally to the side. I'll find my rib number 2, or the costal cartilage for rib number 2. And one finger breath is where's the intercostal space. And that is where I can put my stethoscope to listen to the aortic valve. On the opposite side, so here's on the right-hand side, you have the aortic valve. On the left-hand side, you feel for the sternal angle again. You move laterally, I can hear the pulmonary valve. I can then hear the tricuspid valve. I can then hear the apex beat. These are very, very important. If the apex beat isn't where it should be, so it's normally what we call mid. So if you look at the clavicle, the collarbone, right, if you half the collarbone, normally rib number 1, 2, 3, 4, 5, costal space number, so this is costal space number, 5th intercostal space. So when I say mid-clavicular, it basically means you get the clavicle, you halve it, so right in the center here, and space number 1, space number 2, space number 3, space number 4, space number 5 is where you normally can hear the apex beat, or your heartbeat, what you might feel. If that's not there and has moved laterally or down spaces, what do you think that could suggest? So if you have a displaced apex beat, it could suggest, it could suggest enlargement of the heart. It could suggest left ventricular hypertrophy. It's basically giving you signs that something's not right here. Why can I not listen to that part of the heart? I can't hear that apex beat. Something's not right. How are you going to identify these structures is by knowing the underlying anatomy and being able to identify surface landmarks. If you can't count rib spaces, you're not going to know where to put your stethoscope. You're not going to know what you're listening to. Remember, this is where you can hear the sound. This is not exactly where the aortic valve is, the pulmonary. This is where you hear the sounds. This is not exactly where they sit. And there's a point here where the tricuspid valve is there, but it's best heard on this side. So you can hear it rib number 1, 2, 3, 4, 5th rib. And it's right next to the sternum, so it's medial. And it's intercostal space number 5. And as you move towards the center of the clavicle, you can hear the apex beat. So as a pharmacist, again, it goes back to your fundamentals, your anatomy, you know, understanding the structures underneath. Then you'll be talking about physiology. It's difficult to cover everything in 1 hour, but this is giving you what I'm trying to teach you is, A, don't be scared. Secondly, raise your awareness so you're not being unconsciously incompetent, where you think, oh, this is easy, I know this, but because you have a lack of knowledge, you don't understand things that can go wrong. So counting ribs, is everyone okay with counting ribs? It's going to be really hard to explain that over a webinar, but I'll do a video on YouTube, which you can all watch, and I'll explain it with one of my colleagues, and I'll go through how to count rib spaces, but we'll move on because I want to really get into history taking. So this is just a point here about where to listen to the various areas of the lungs when you below the armpit, or what we call the axilla. So it's just something that's worth you remembering, that the lungs actually extend all the way at the back and they don't end just here. It's really important for you to know that the lungs do extend mid-axillary point. So if you were to have your armpit here, you have the anterior axillary line, and then in between the armpit, you have the mid-axillary line that divides it here. We call that the axilla, the mid-axillary line. and the lungs do extend backwards as well. So that's really important for you to know that yes, you're going to listen to chest sounds here, but you must listen to chest sounds at the axilla as well. Why that's important is because sometimes you'll hear just small amounts of infections or crepitus and so forth just in the corners. So as much as listening at the front, you've got to listen to just in the corner as well. And I've explained this to you about here. Okay, let's now move on to history taking, because this is going to be fun. Right, this is my framework I use all the time. This is something you need to take a picture of, memorize it, understand it, but now you need to all start to get involved with this. This is my structure. Every time that I see a patient, I'm thinking, okay, rule number one, is this patient unwell? So if we had a patient with a cough, the first thing I'm thinking is this patient unwell? Does this patient, let's use Sadikor example, if Sadikor was to present at the clinic, the first thing I'm thinking is Sadikor actually unwell? Does he look not well? Is this someone I should be dealing with? We've all seen it when people are unwell. You can look at their color, you can look at their mannerisms. Just go back when you were extremely unwell, what it looked like, what it felt like. If you've got a patient who presents to you who's absolutely gasping for air, you know, sweating, in pain, blue, you're not the best clinician at that point to deal with that. Not because you're not capable, because you don't have the tools to be able to deal with that. Once I've done that, then you always remember that you always look first. How important is a physical examination? How important is a physical examination? If you had a choice between listening to your patient and doing a physical exam, which one would you choose? 10 out of 10 times. Anybody else want to give it? Anybody else want to share? So, Bobby, yeah. The most important tool that you have is listening to that patient, taking the history. The physical examination is there to help you formulate or verify your diagnosis or object that diagnosis. The most important thing is you being able to listen to that patient's story, compare that story to likely other stories or diagnosis that would present and paint a picture, and then come up with a diagnosis. This is what I'm doing all the time. I'm always listening to my patient. I think about the physical examination at the end, because majority is going to be me listening to that patient. If I don't take or not able to get his story and compare it to a disease state, you can do all the physical examination you want, you're in trouble. You don't know what you're doing. You're wasting time. You won't understand. So I always observe the patient. I then, I'm then, looking for airway, looking for breathing, and then this goes back into, is this patient unwell? You get consent. I then remember that I'm comparing stories. I'm thinking of differential diagnosis straight away. As soon as the patient, let's say, presents with a cough, I am thinking of, okay, what are my possible differential? The moment he mentions I've got a cough, my mind is thinking straight away that, okay, at the back of my head, I've got to be thinking of the possible differential diagnosis or the diseases that can cause a cough. After that, I've got to think, is there anything in there that's making me worried that this might be something a bit serious? And then what examinations would I need to do to verify or not verify? So I want you to use this information and apply this to this case. So the history taking structure, who knows, have you ever heard of a presenting complaint, history of presenting complaint, past medical history, family history, social history, sexual history, travel history, drug history, and so forth, and review of symptoms? Yeah. And is there anybody who's never taken a history before, or thinks they don't take a history? I used to think that 2 years ago. I don't take a history, but even WAM, is a history. It's a very focused history, but it is a history. All you're doing is gathering information. And the reason you're gathering information is because you want to gather that information and compare it to different diagnosis. That's what you want to do. You want to compare it, that knowledge, to different potential diseases that present with the same symptoms. What's the difference between a sign and a symptom? Are they the same thing? A sign and a symptom, are they, what's the symptom and what's a sign? So a symptom is what the patient tells you, but you can't really verify. A sign is what you can verify. For example, temperature, thermometer, clear. Symptom would be chest pain, or a symptom would be, I'm having shortness of breath. So symptoms are very, what we call subjective. So it's what the patient tells you. A sign is objective, where you can identify that. Oh, your pulse is up, I can measure that. Yeah, you're right, 100 beats per minute. Your breathing is up, I can measure that. Your temperature, I can measure. Symptoms are very, very important because that's a subjective story and that's what you're comparing. But whenever I take a history, I have this set structure. I have this presenting complaint. I then have a history of presenting complaint, what I'm going to ask for: onset, location, duration, character, aggravating factors, associated factors, relief, and treatment. I then go into the past medical history. I then look at the family history, social history, sexual history, and so forth. But this structure is so important. What I do is literally, as soon as the patient comes, I write down my headings: PC, HPC, SC, and break it down straight away. I memorize it, I write it down, so I don't miss anything. And you can remember it through remembering old cart for your history of presenting. What's the onset? What's the location? What's the duration? What's the character? What are the aggravating factors? What are the associated symptoms, relieving systems, and treatment? And this will allow you to gather and extract that information without you missing anything. Then you have your past medical history, you have family history. Why is family history important? As I move on to the next slide, why do we care about the family history? So what? If this patient has a cough, why is it important for, let's talk about respiratory, why is it important family history? Why do you need to ask the patient, tell me a bit about your family history? He's got a cough, what do you want to know for his family history? Yeah, yeah, exactly. Some sort of cancer, some sort of link to the disease. You want to be able to identify. If you had a 50-year-old patient with a cough and has a family history of cancers, alarm bells should be ringing. That 50-year-old patient with a cough has a family history of cancers, obviously coupled with everything else, you need to be thinking. So we're going to go through that in a second, that a cough is a cough, but a cough is a sign that something isn't right. A cough is a sign because you can verify that, you can hear it and so forth, something's not right. Social history, what's important for the social history? Why is occupation important with a cough? I'm not going to mention smoking because we know that. Why is asbestos? Yeah. What else? Asbestos is straightforward. What else? What else? Occupation. Yeah. Farmer's lung. That's right. So there's certain occupations that can put you at risk. Mining. Yeah. There's certain occupations that can put you at risk of other diseases, and that's why it's important for you to know that. I've never come across a patient with farmer's lung, mining, or asbestos, but it's good to have that knowledge. Smoking, very, very important. Very, very important, because if they're smoking, I always slightly lower my threshold for disease states, antibiotic prescribing, and so forth, because I'm thinking smoking. Alcohol, yeah, we know that's a risk factor. Drug allergies, for a cough, pharmacists, I'm not even going to mention it, but we should all know certain medicines that can cause coughs. What about travel history? Why is travel history important? What we thinking about travel history? Yeah, malaria, but more for yeah, TB. Absolutely, TB. TB is important. So travel history is important as well. If this patient's been to let's say this yeah, atypical pneumonia, great, very, very important. So again, these are important things. If you don't know them, it doesn't matter because you're going to learn them. It's not about you being able to recall stuff, it's what you do with it. It's great being able to mention TB, atypical pneumonia, colitis, but if you don't know what to do with it, you don't know how to recognize it, you don't know the pathology, you don't understand the physiology, you can read a book and list all these things, but application is important. You can get a book on differential diagnosis that'll give you all the differentials, but do you actually know what to do with that? So, that's so don't worry about it. Anybody who's thinking, wow, where's this knowledge coming from, does not make a slightest difference at all. You're going to learn it as well. It's not rocket science. You can go on Google, it'll probably tell you what the differentials are. So 36-year-old patient presents with a cough. Who would like to start? What's the first thing you're going to do? What's the first thing you're going to do? Let's say, let me make it easy. So, yep, so how they look. Okay, so this patient looks the way I'm looking now. I hope I don't look unwell, but okay, so that's the absolute first thing you do. You're looking for the look. What would be, Nazmus, what would be concerning for you? If you had a person with a cough, what would make you a bit concerned? In the way that they look, that you would be like, nah, I'm not happy about this. I don't want to be dealing with this case, or this case is not for me. Yeah. We're going to get to the history in a second. We're literally just following the acronym where we're trying to focus on that structure. We're going to look first. Before we do any history taking, we're going to look. Color, and so a lot of people mention cyanosis, and cyanosis is important. Cyanosis is very important, but cyanosis is actually a decrease of oxygen to tissue, and it's a very serious condition. I would be very surprised if you saw a patient with cyanosis present to your clinic, because if they're cyanotic, there's other stuff that's definitely a lot wrong with them before they get cyanotic. But yep, you're observing color. Use of accessory muscles, that's right, pursed lips. Other thing I was looking for is breathing rate. Breathing rate is so important for patients who present with any sort of respiratory disease. Breathing rate is important. What's the normal breathing rate? Somebody who hasn't answered, you can search it on Google. Farah seemed to be very quiet today. Munam, you're a bit quiet. Shoaib, looking nice, yeah. Sandy, William, anybody else? Lola, want to give it a go? If you don't know, it's fine. I didn't know. The first time one of the clinicians asked me to measure the pulse, didn't have a clue. What he said to me, measure the heart rate. I thought, can't do an ECG, I don't have an echo, it's just the pulse. So it's if you don't know, it's fine. But the more you engage, the more you get involved, it just makes it a lot better for you, and you can learn a lot more. But yeah, 12 to 20 beats. So normally 12 to 18, but that's correct. What about for children? Is it different in children? Yeah, so you need to, again, you don't have to memorize this. You don't have to, yeah, thank you, William. You don't have to memorize this. You can get a chart, write it down. In any McLeod's book, they have a beautiful section at the back of the McLeod's book. And by the way, you don't need to even pay for this stuff. If you're unsure, let me know. There's PDF drive. You can download books for free. So you don't need to pay for books. Although I don't think we should be advocating that. My bad. Ignore that. But the McLeod's book at the end has a nice section on peds, and it nicely breaks down the different vital signs. So perfect. So we have this patient. You've looked for the color. You've checked for the vital sign. What next? Let's go to the history taking structure. What are you thinking? I've said cough. What's the next question that you're going to be thinking? What do you want to ask? That might make it easier for you. So we've got our presenting complaint is, yes, 30-year-old with cough. I think I'm 30 or 31, I can't remember. Absolutely. How long, Darren, beautiful, Nazimus, beautiful, Monam, beautiful. How long? Onset, before we get to productive, the key is the length. You could even go down the route of productive as well. But you see, the trouble with productive is that certain coughs you want to be careful with. If you have a patient that has a cough for 8 to 9 weeks, or 12 weeks, or 16 weeks, does it make a difference to you if it's productive or not productive? Are you really going to take on that case? Or should that be referred? Unless you were in that setting where you would be the person dealing with that case. Yeah, so I'm talking from a pharmacist perspective, even as a prescriber. If I had a patient who presented with a cough for more than 8 weeks, the reason I would refer, not because I'm not capable of dealing with it, because we might need an X-ray. When was the last time any one of you went to the doctor, had a cough for 8 weeks, he referred you for an X-ray? I had it. Even the first thing he did was to refer me to X-ray straight away. He didn't even faff about. He just said, okay, you've had it for 12 weeks, we need to find out why is the cough going on for so long. So with the cough, we can nicely break it down. The moment they've got that cough and you ask them, sir, madam, how long have you had the cough for? And she or he says, less than 3 weeks, less than 6 weeks, I can deal with that. Less than 8 weeks, I'm happy with that. Because why is the duration important? What is it about the duration that's important? What's going to change if the duration gets longer? Yeah, could be. So basically your differentials are going to change. All of a sudden you're thinking, you know what? This guy's had a cough for 16 weeks. Could it really just be a viral upper respiratory tract infection? You know, what's going on? This is I can't just go with upper respiratory tract infection or infection. It could be, but this cough has gone on for so long now. My thinking has to change, and this is all about pathology. This doesn't come from reading a couple of differentials, knowing this is all about pathology. We're not even touching pathology. This is all about you understanding diseases. So we've got presenting complaint. We've got into the history. The first thing you've asked me for the duration. So if we break it down, HPC, you've got OLCART, OLDCAART. So onset has been 3 weeks. Duration, regular. Now we go to character. Now you want to know, is it a productive cough or is it a non-productive cough? But the moment you've got the onset, can anyone list some differentials it could be? If I said it's a 3-week cough, I'm thinking differential straight away. Everybody name me one differential that they think it can be. And that will cover majority of it. Between us, I'll do one. Oh God, you've done the easy one. I'll do one. There you go. So I've done my part. So upper respiratory tract, lower respiratory tract, that's going to cover your pneumonias. That's going to cover all that. So you can't say pneumonia, bronchitis. That's all now culminated in one. So what else have we got? Asthma, well done, Munam. So we've got congestive heart failure. We've got asthma, upper respiratory, lower respiratory, COPD. So we've got 5. TB 6. Pneumonia. This is an adult, so croup possibly, but avoid, unlikely that they're going to have croup. Pulmonary embolism 7. Anybody know what a P is? Everybody know what an embolism is when a clot? So we've got 7. What else have we got? We've got 7 so far. Between us, we've listed 7. Okay, so our list remaining. So this slide says if it's less than 3 weeks, yeah, oh, well done, Darren, that is lovely. I'm liking that, because that's one that always gets missed out. Gourd, always, you know, can get missed out. It does get missed out. But based on probability, if this person has a cough that's about less than 3 weeks, you're looking at these. If it's more than 3 to 8 weeks, and lung malignancy can also go chronic. So don't think that anybody who has a cough that's more than 3 weeks is got lung malignancy. But once it goes beyond 3 weeks, we're thinking of other things. It could be pulse nasal drip, very important, asthma or GORD, and obviously lung malignancy and so forth. So the duration is going to be important. Tomorrow, when you see a patient with a cough, the first thing you're going to ask is, okay, tell me how long you've had the cough for. The moment he says, oh, it's been less than 8 weeks, I'm a bit more relaxed. Okay, less than 8 weeks, fine, I can deal with this. Differentials that I had were these. So again, probability wise, common is common. And me and Sadiq were talking about this today. You know, I had a long discussion with the doctors, and they're like, Fahim, it's great you having all this knowledge, you know your differentials, you know pathology is all good, but common is common. There's no need to be over smart. Common is common. If this person has a cough for 3 weeks and it presents as a common cold, it's probably a common cold. Don't rush to, oh, it could be left ventricular heart failure, could be GORD, could be lung tumor, could be this, that. Common is common. So don't be scared of that. And you don't need to be, you don't need to be scared. You need to be scared of the unknown, but it's not unknown to you anymore. What I'm trying to teach you isn't really history taking, isn't really pathology, isn't even the science. Is giving you the confidence that you're able to do this. There is no reason why you are not more than capable of actually dealing with these cases easily. What's stopping us all is not having that knowledge. That's what scares us. Okay, wait a second, this cough could be any one of these. Now you know what it could be. There is nothing to be scared of. Once you know what conditions they are, then you've read the pathology, you understand physiology, you know microbiology. This is easy peasy. No rocket science. No rocket science whatsoever. And I don't need to go to university and get a doctor's degree or go ahead and start doing other bits and pieces of major learning to get numbers behind. You don't need that. With the right teacher, the right investment in your time, in 6 months, you could absolutely 40 conditions, 50 conditions, easy peasy. You don't need to spend 3 years. If I was going to spend 3 years on learning, I would probably go and do medicine. That's my opinion. If I can do it, anybody can do it. And there's no reason to be scared. When you need to be scared is when you don't have that knowledge. And Bobby can testify this, who's on the chat, and he's actually been qualified for a couple of years now, and now he's pretty much prescribing full on. And it was on the back of the discussion that we had, where I explained to him, and he said, "Look, you know what? You're right. This is I can do this. I've just been scared of the unknown, but I don't need to overthink it." And if he's now prescribing, and I'm sure Bobby will anything to say to that. But it's for me, it's a pleasure, because just with the discussion that we had, he's doing it now, and he's asking, Bobby, how many people are you seeing a day now, roughly, in your clinic? Easily 3 a day, and that's with him not wanting that much more patients, but he's seeing 3 a day, day in, day out. And he's not treating everything, but now, no advertising, nothing, just 3 a day, just with him. I'm guessing you're just working the shop, somebody turns up and you can see them, right? That's probably how he's doing it now. 3 a day. 3 a day, and if he's charging anywhere between 25, 30 quid, that's an extra 100 quid in the bag. 100 quid times 5, 2,000 pounds in his back pocket, excluding if he's charging them for drugs and so forth. But he now realizes, actually, I can do this. This is not rocket science. With the hard work, with the right training, with the application, the discipline, it's achievable. Any one of us can do it. And I was thrilled when he said to me, Fahim, after I've spoken to you, I'm doing it because you're right. If you can do it, why can't I do it? There's nothing rocket science about it, but with the right training. So these are some of the common, these are some of the occasional, and these are the rare ones that you got to be aware of. You know, fibrosing alveolitis, inhaled foreign body, pulmonary embolism. Because with the pulmonary embolism, the cough isn't the main feature. You're going to have other features, but a common patient who presents with a cough, you are more than capable with the right training, being able to do a proper physical examination, you're able to deal with this. So we've done the presenting complaint, we've got the history, we've got the duration, we've now listed our differentials. The next step that you need to know is the pathology for these. You need to understand inside out. What is asthma? What is its causes? How do you diagnose it? Same thing with COPD. Same thing with GORD. Same thing with left ventricular heart failure. What's the very common characteristics of someone who's suffering with left ventricular heart failure? What they're going to have they may have a cough. What else are they going to have? A cough. What else are they going to have? What other symptom are they going to have? So you've got a cough. What would make you gear you more towards maybe a kind of ankle swelling, something a bit more, yeah, shortness of breath. Absolutely, shortness of breath. So if you've got a patient who's just got a cough for 3 weeks, he's not coughing up sputum, it's just a cough for 3 weeks, it really slowly starts to make it a lot easier. But once you introduce a cough that's productive, then you've got to think about the pneumonias, then you've got to think about the temperatures. And what about the color? If it's yellow, what does that suggest? Mucus. What does yellow mucus suggest? If it's yellow, if it's green, and why? Why? Why that color? So if you have a patient has yellow cough or has a cough that is green, why is that relevant? What does that suggest? Yeah? An infection. What kind of infection? Does it tell you anything about the infection? Does it tell you what type of infection it can be? Oh, pharmacists, we're jumping for the bacterial. Jumping for that bacterial. Viral or bacterial. You can't really diagnose somebody. It's difficult to just based on the color of the phlegm. It's difficult to base that you've definitely got bacterial infection. We'll have to include other things with that. Why the color changes? Because dead neutrophils and eosinophils, when they die and they destroy the gunk, this green or this yellowy mucus is formed, because the normal color of mucus is normally clear. When it goes yellow, when it goes green, basically you're having a pathology. Something isn't right. Next time you cough up and it's clear, it's good. The moment it goes yellow, it goes green, obviously if it's red, something isn't right. But the color of the mucus can tell you that there's an infection happening. It can tell you other characteristics, but it can't tell you that it's definitely bacterial viral. So that's important. Alarm features. I'm not a big advocate of red flags. We know that because I don't like red flags. What I like you to do is to understand it. But what you need to just basically focus on is there are certain features of a cough that need you to think of other things that rank the differential slightly higher. So if you had a patient who's got a cough and has got hemoptysis, which is bleeding or blood, then your differentials would change. Then you're thinking, could be one of these. Could be TB, could be pneumonia. Ignore the cancer for now. Could be acute viral bacterial bronchitis. Fine. Couple that with a fever. Could be pneumonia. You now have a patient who's got fever, shaking, productive cough. Even without you doing a physical examination, you're thinking, you know what, this might be a bit bacterial. I need to be careful with this. He's got a cough, he's got a fever, he's got sputum. I'm thinking more. So these are what I call alarm features. Wheeze, shortness of breath. All of a sudden you think asthma. You're thinking COPD. You're thinking left ventricular heart failure. Chest pain is that's, if he's saying he's got chest pain, you've got pneumonias, you've got left ventricular heart failures, acute coronary syndromes. The heart's going to be involved as well, because heart and lungs, brother and sister. If you've got a lung problem, heart's going to be following soon. If you've got a heart problem, lungs are going to be following soon. So cough if it's a lot of mucus, you've got other differentials. If there's weight loss, you're now thinking a totally different list of differentials. If they've got shortness of breath at night, you've got low extremity edema, could be an embolism, could be congestive heart failure. So this is how the model works. So whenever I take a history, the first thing that I do is I always observe the patient. So let's say we had Farah present to the pharmacy or to the clinic. I will first observe Farah. Is this patient unwell? Step number 1. Step number 2, I will always then get their details, which is important. You need the name, address, contact number for a review follow-up, name, address, contact number, male or female, date of birth. Then I ask the patient, once I've done all the, the tick box stuff, is, Farah, how can I help you today? She will then tell her story. I've had a cough. As soon as she mentioned that first symptom, my head is going, thinking, okay, differentials. Sometimes I've got a book, I'll go back and pop out, check in the book that actually, I can't remember. I had a patient just earlier on who had discharge, vaginal discharge. And I was thinking, okay, bacterial vaginosis, trachomas, thrush, could be a foreign body, could be all sorts of other things. What could it be? It could be an STD or an STI, but I just went blank. I said, I took the history, I went back and opened my books that, okay, let me go back to it again. So you've got your presenting complaint, cough, think of differentials straight away. Then your list of differentials, you need to understand the pathology. Without you understanding how these diseases manifest in a person, you can't do much with it. You can take a history, you can ask them onset, location, duration, character, associated symptoms, aggravating symptoms, signs, the whole thing, but you're not going to be able to merge because you don't understand how these diseases actually manifest themselves in a patient. So then I will, once I've taken a history, once I've got the presenting complaint, I list my differentials on one side. I then start to take it. I'm listening to that patient. I then start to take it after I've taken the vitals, obviously, because their respiratory rate, temperature, vitals are important. You should be taking vitals all the time. Respiratory rate, beats per minute, BP, temp. Never rule these out. These are so important because they'll tell you what's happening in the human body. They give you a quick snapshot what's going on. If this patient has the heart rate's increased, the blood pressure is low, something isn't right. Why is my heart trying to beat faster, but the blood pressure is low? Because the heart wants to get that blood around and the blood pressure is it's not being able to, something isn't well. This person is now maybe hemodynamically unstable. That homeostasis, which is all about maintaining that balance between normal function and abnormal function, something's not right. So vitals are always important. If your vitals are not right, something isn't right with this patient. So I've got the vitals, I've got the presenting complaint, I've got the history of presenting complaint. I then take a social history, a family history. I then start to compare the stories, and then I do a diagnosis. And that's basically, that is that in a nutshell. You have to go back, you have to practice history taking, you have to read up the disease states, you then need to understand microbiology, because you can't prescribe antibiotics without understanding microbiology, because you're going to just keep prescribing amoxicillin, and sometimes it doesn't need amoxicillin, doxycycline, and so forth. So you need to understand the whole, the human body is, you got to give it respect. You can't disrespect the human body and jump hoops. There is no jumping hoops. If you're going to jump hoops, you're going to get yourself in trouble. There is a right way to learn this. You can be as smart as you want. You can be as clever as you want. You can be as as you know, as brainy as you want, there is a pathway that you have to follow to get good at this. That is your anatomy, physiology, pathology, hands-on practice, someone to teach you or to guide you. You can do this. No rocket science. Anybody got any questions? Any questions about anything? Anything to do with business you might want to ask me? Any tips on aesthetics? A lot of you have got in, keep asking me about aesthetics. Everybody gets in touch, asks me about aesthetics. Oh, you know, could you tell me about aesthetics? Anybody want to know about aesthetics? Anybody want to have any information at setting up a clinic? Anybody having trouble in their workplace in the sense that GP surgery? Any questions? It doesn't have to be about the webinar. It can be anything. Let me know. You could. I'm more than happy to answer that question. But my main thing to you guys is enjoy your life, guys. Do what you want to do. You shouldn't be doing things you don't enjoy. And you know, I spoke to Brother Nazmus about a week ago, and inshallah, he's absolutely determined that this year he's going to absolutely change his plan. He's made a conscious decision that I'm not going to keep on doing what I'm doing. I don't enjoy it. I'm going to make a difference, and he's doing it. He's, you know, and you have to invest in yourself, guys. You have to pay. You have to part with some value. If you start to value that paper money more than knowledge, it's a mistake. It's a mistake. It's the biggest mistake you can make. If you start to disvalue knowledge and think, you know what, this £100, this £10, this 30, this £1,000, no, I shouldn't pay. Ooh, it's a big mistake. I've done that. If you want everything for free, then you're going to get stuff that's free. Simple as that. So it's really, really important for you to understand that you can do it. Parting with your money is not the end of the world. Q&A, someone's got. Oh, best way to contact me, here's my number. Last time Sadikur was saying that I'm going to tell your wife that this guy keeps giving his number out, and he's going to get me in trouble. He's like, he puts his numbers on the slides. He just, you know, he puts his number on the slides. Thank God, you know, I blagged my way out that one, and I said it's Sadikur. He keeps giving my number. I've never given my number to anyone. He's always putting it on my side, and it's not me. So that's my number. Get in touch with me directly. If there's nothing you'd like to ask now, get in touch with me directly. There's plenty you can do. I wish you all a wonderful evening. Thank you for your time. That's my number. Send me a message, inshallah, and we take it from there. Sadikur, thank you for organizing everything, and I'll see everybody next week.